Thanks so much, Ravi. That was really very enlightening and very lucid, and you tried to share the experience from all across the world. So I think there are some telling points from your presentation. So the volume of transplant activity coming down across the globe, and you mentioned the survey that you and Srinivas Reddy did, probably could be because of two reasons. And what we saw in our experience was that the referrals had come down. So the patients were not being referred for transplant from districts, whether it was the patient's own inclination not to travel or whether there was a lockdown and it was not feasible for patients to travel across districts. So I think that is something that one needs to factor in. And probably in the Western world, the system got overwhelmed by the sheer volume of cases. So I think they started to think that probably transplant is an activity which is more elective, and therefore they might not want to embark on transplants during the peak of the epidemic. So probably that is my take on this.
Agree. In fact, if you notice, there are two centers in the US. The one in New York had very high reduction of volume, 80%. The other one had 60% reduction in the volume.
Yeah.
So you're right.
There's also data to suggest that even the brain dead declarations had come down substantially. So most of the intensive care staff was caring for patients who had come in with the COVID pneumonias and the severe COVID-19 infections, and therefore the effort that was being given to the other specialities, and this is something which everybody is vouched for, that had come down substantially. For us, of course, the referrals had also come down. So our system never got overwhelmed by the COVID-19 cases, but the referral pattern had come down substantially. So only very sick patients were coming to the transplant center, and that's why you mentioned the high MELD score and the tumor thing. I think what we also did during the course of this study, and which is worth mentioning to those who've logged in, is that we always gave the option to the recipients to understand that we are going through very difficult times and uncertain times, and therefore if they would want the surgery to not happen, and that we had started to include in the consent form. So that is what we had started to do at Global. So at all the 4 units, we started to reframe the consent for the patients who are undergoing transplant during this period. I invite Dr. Vishali and Dr. Rajshekar Peramula for their comments or anything they might want to talk about from Dr. Ravi's talk or from their experience per se.
Do you or Ravi, both of you can answer this? Do you have any special comments for seropositive patients like Hep B or Hep C in the recipients wise for COVID, for taking care after transplant?
So there is no data specifically for Hep B or C patients, but because we have good antivirals for both, it shouldn't be any different. What do you think?
So hepatitis B, you would continue to have these patients on the nukes, and for hepatitis C, it's you might want to see on a case-to-case basis. That's a tricky one. Most of us nowadays actually treat hepatitis C patients prior to them undergoing transplant. Only those who have got a borderline MELD, which would be anywhere between 18 to 21, one would be reluctant to treat them pre-transplant, and you would want to take those patients post-transplant. So I think that is something that you need to decide on a case-to-case basis. Please remember, remdesivir is a drug which was first discovered for hepatitis C way back in 2009. Didn't work in hepatitis C, and then later on tried for Ebola virus, and it's done its rounds before it is now stuck gold with COVID-19. So I think hepatitis C is something that you'll have to take on a case-to-case basis. Dr. Rajshekar?
Dr. Dharmesh and Dr. Ravi Monkar, what is the risk of co-infections in these patients who have developed actually this COVID status in the post-operative period actually across the studies?
So sorry, say that again. What is
co-infections like fungal or any severe bacterial infections in these patients who have become COVID positive in the...
So in our series, we did not see the profile of infections in the post-operative period different. But like Dr. Ravi mentioned, we just stuck to the script. We did not change their immunosuppression at all. So we were just doing what we were doing in the pre-COVID era. So I think the most important thing, and this is something that needs to be reiterated, is that COVID should not be treated like a sepsis in a transplant setting. So these patients are not immune deficient per se. So if you are suddenly taking off the immunosuppression, thinking that being on immunosuppression is going to increase the risk of this infection, then that is not true. In fact, my own experience has been that people who have been some years into transplant are more likely to develop the COVID infection, though there could be two reasons for that. A, that they are on a lower immunosuppression and therefore they are able to mount a cytokine response. It could also as well be that they are in the community and they have been some years into transplant and they have thrown caution to winds. So we have not actually seen a very high number of COVID infections in the immediate post-transplant period. In fact, I have seen none. So we have not seen any COVID infection in the post-transplant period. So my own thinking is that there is something more to it than meets the eye. So it's not just the, and like Ravi said, it's very important that you should not suddenly take off all immunosuppression. If you suddenly take your foot off the pedal, then there is going to be a resurgence of the immune system. There is one very interesting basic science publication in the mice model of COVID infection. So they took two varieties of mice, one in which there was an interferon knockout mouse. So we know that RNA viruses, their first response is to generate interferon by way of the innate immune pathways. But they found, as luck would have it, the mice who were interferon knockout, they had got a higher chance of dying. So this is something that we need to remember. So it is, so the response of the human body to RNA viruses is very important. So it is not just so because these people are on immunosuppression and suddenly you take your foot off the pedal, there will be a resurgence and these people will have a more severe disease. That is what we feel. So you should not too much tinker with their immunosuppression. What we have been doing is to take off the anti-metabolites because many of our patients are lymphocytopenic by virtue of, so please remember the immunosuppression in solid organ transplants renders you lymphocytopenic. It does not render you neutropenic, unlike the hematopoietic stem cell transplant. So the two situations are very different. So one has to be very careful. If you suddenly stop all immunosuppression, you might land up with patients who've got more severe infections and they will have a higher mortality.
There are other questions I'd like to ask you if you permit it. Any cautions in using this monoclonal antibiotic? There are a number of monoclonal antibiotics being used for this COVID patients in post-transplant. So any drug-to-drug interactions or any cautions to be taken when using these things?
So I had a slide there. So there are a lot of drug interactions that are possible, but we have to just basically remember that this is a IL-6 inhibitor, tocilizumab. So therefore, if you use it with other immunosuppression, then you could be doing a lot of the over immunosuppressing them because that's also immunosuppressive. The others are antiviral, so they don't, except for the interaction itself, you can just adjust the dose. But tocilizumab, you have to remember that you may be over immunosuppressing the patient because of this.
Thanks.
So the most important interactions in this, Dr. Rajshekar, is of hydroxychloroquine because oftentimes you just prescribe it over the phone, thinking that this is something which is very straightforward and easy for the patient to take and cheap too. So there is no evidence that it works, and hydroxychloroquine is a very strong promoter of the P-glycoprotein efflux. In fact, it's an inhibitor of that. So that is why patients who are on hydroxychloroquine, they are likely to have very high levels of the CNIs as well as mTOR inhibitors. So one has to be very cautious when you are using this. The second very important drug interaction is when you are using protease inhibitors. So in our part of the world, there have not been too many people who've taken up ritonavir boosted protease inhibitors, especially lopinavir. But there are case reports that TAC levels have gone to humongous levels when people have used this. So this is again something which is a CYP pathway inhibitor, and therefore you can have very high TAC doses. And I think that is also one of the reasons, because of the interactions, that you find that diarrhea and AKI is far more common in this population. So I think these are two very important interactions, and tocilizumab actually is something which is going to fall by the wayside. In fact, even the Western world has realized that this drug doesn't work too well. More importantly is when patients with liver disease who have not been transplanted and are given these drugs, and oftentimes you get a consult with liver function test abnormalities in them, and that is something which every hepatologist should be having enough exposure to be able to decide on a case-to-case basis whether it is the virus or it is the drug that has caused this. So again, that is something that one has to watch out for.
Thank you. Thank you.
Dr. Nemish, you want to share your center's experience during the COVID pandemic? You have to unmute yourself.
Thank you. So yes, I agree. The numbers had come down significantly, and during the first 3 months, actually, we had not done any transplants. So we started doing transplant last month, and we are following after what the LTSI has given the guidelines, and note on the LTSI guidelines are being religiously followed. One question which I had put up to Dr. Ravi was, how often would you check the healthcare workers? And I think he has already replied to me back saying that we test the healthcare workers, because that is one very important point. We keep on talking about testing the recipient, testing the donor, but how often are you going to check the healthcare workers who are involved in transplant? So I think Mumbai and ZTCC probably advises to test only if they are symptomatic.
Even the NOTO guidelines, same thing.
Yeah, correct.
So I think this is just going to open the Pandora's box. So I have very strong views on testing. So Ravi mentioned that if you are PCR negative, you should become IgG positive, and then only it is to proceed with transplant. So we know that patients with chronic liver disease, not just liver disease, any chronic affection, whether it's heart failure, cor pulmonale, chronic kidney disease, they do not mount antibodies so well. We know at best the sensitivity of nasopharyngeal swabs is only about 63%. So I don't think what we are talking of. So what we started to do, and this protocol was first initiated at the Hyderabad unit, and then I think everyone else followed because there was some merit in it, that we used to get the patients on board a few days prior to transplant. And now I am talking only of the living donor transplants. As regards the deceased donor transplants, we had to make sure that the donor was stable. So if you had a donor who'd just come into the hospital, brain dead declaration was done, we would be unhappy to accept the organ if we had not spent quote unquote enough time with the donor. So this was obviously a COVID screening CT at the time of admission and a nasopharyngeal swab after the brain death declaration was done, and then this patient needed to be stable before you would go ahead and retrieve the organ. And something that one should not be doing, but we have been doing, and so far it has held us in good stead, is that even in living donor transplants, we are getting the donors on board a few days prior to the planned surgery, so that you know that there are no breakthrough symptoms. So please remember saying that if you tick the epidemiologic boxes and you have done the CT, so you know that, so all of us have seen cases where the CT is not showing anything. It's a Conrad 0, but the swab turns out positive, and vice versa too, that the CT is showing florid changes and the swab is not showing a positivity. So it's very difficult. So I think what really matters is the temporal course. And if situation is not going out of hand, one would want to spend as much time with both the donor and recipient. In fact, there is very interesting write-up from many centers in the US where mostly deceased donor transplants happen. There is a severe constraint on testing for COVID. So if I pose this question to this audience, so if you have got a donor and a recipient, whom would you want to test?
Both.
The answer is the donor. So if you have constraints, you want to test the donor, not the recipient, because the donor is one who's been languishing in the ICU for some day and much higher chance of contracting the COVID while he's in the hospital. So I think these things, they make a lot of sense, but at the same time, to each his own. So we have to have our own plans in place to decide how we want to go about the testing. The IgG thing, I know the LTSI, and one of my fellow surgical colleagues, I hope he's logged in and he's listening, vouches by the LTSI, but I don't believe their guidelines. So we know when you immunize patients who have got end-stage liver disease, they hardly mount an antibody response. So how do you think that you had an infection in the past, you will get a positive IgG? I'm not very sure you would. Dr. Vikram, Dr. Somnath, if you are around, do you want to?
There are different panels, no, for this.
Yeah, doesn't matter, sir. I think.
Okay, go ahead.
Yeah.
I will pitch in at some time. I have got few slides to show about the DDL.
Sure. So no one else is coming, sir. Please go ahead, sir.
Okay, I have to request the organized Emcure person to put on my slides. I can't do it from my. Yeah, please. Yeah, Dharmesh, what you are saying is right, that that donor should be in the disease donor I am talking about. Okay. Can you go to the next one, please? Next. Quick. So I'm going to talk about how we went about in Mumbai. okay, to get the transplant program going on. And these guidelines or SOP we prepared in around 16th of March, and later on we got ratified by the DHS, which got notified on 4th of June. And our prime concerns were basically safety of healthcare professionals, which includes all, including the coordinators and ward boys and everybody. And second is how to prevent the transmission, what Dharmesh was insisting on, from the donor to the recipient. While in the living donor, it may be other way around also. And also from donor to the health professional and vice versa. And the third, because most of the hospitals are mixed COVID hospitals, where there are COVID patients and non-COVID patients, that the transplant area and the patients who are COVID positive area should be totally segregated. And that's why we asked the hospital who can do this, and those who are willing, they were allowed to continue with the transplant activity. And you will be surprised that only 1/3 of the hospitals out of 39 were willing to do the transplant during this period. Next one, please. Next one, please. Go to the next slide, please. Yeah. And Ravi has already said that we had a 4-step screening for the disease donors, and usually they are tested twice. I would like to emphasize on that we insist on endotracheal secretion being negative. We just don't rely on the nasopharyngeal or oropharyngeal swab in the disease donor. We want the endotracheal secretion to be tested for the RT-PCR, and if that is negative, CT chest is negative, and epidemiological and clinical history is negative, then only the donor is accepted. We had one, I'll give you the example where we ruled out the donor on the basis of cause of brain death. This person was declared as a CVA, but the CT brain, which was showing, were actually microthrombi and the microinfarct. It was not like classical CVA. And all of us discussed, and we said, no, this could be COVID, because the CT chest was showing some shadows, and we discarded that. Next, please. Okay. Regarding a healthcare worker, I think just the epidemiological and the clinical screening is good enough. If any of them is positive, he should be out of the team and should go on to the pathway of getting tested and getting quarantined or isolated. Next one. Okay. The transplant specific, COVID specific consent, a detailed consent has been drafted, and this is to be taken from every recipient. Yeah, recipient testing is there, but we don't insist on that the recipient report should be available before the transplant is done. Next one. Next one, yeah. So this is there were 10 disease donations which happened from March to July. This is 20% of the normal donation activity in Mumbai. So it is definitely reduction. And 29 organs were retrieved and transplanted, out of which 10 were the liver. Next one. And following this strict protocol, we'll see that there were 307 healthcare workers, doctors, nurses, everybody was involved in these transplants. Okay, whether it was retrieval or during the transplantation. We have followed them for 28 days, which is a mandatory follow-up, and no one has developed COVID, including the recipient. So that shows that if we follow the protocols strictly, in the true sense, the transplantation can be done, disease donation, I'm talking about, safely during this COVID era. Yeah, that's all. Dharmesh, you can take over from here again. Yeah, you are not audible, Dharmesh.
Sorry for that. So I think that was really great to have been able to manage so many donations during this period. The donations in south of India have just dried out in the last few months. And I suspect it's probably to do with the containment zones and very little by way of vehicular traffic, and therefore the number of BD declarations and even the neurosurgical admissions, they have come down substantially in the southern states. I think we've had a very fascinating 1.5 to 2 hours of discussion. There have been many good takeaway points, and I just hope that people who've logged into this webinar at least have gained something. I now hand it over to Sandeepan to conclude, and if anything else he might want to suggest, and if such activities are really appreciated. Oh, Dr. Sonal is there. Dr. Sonal, you want to share your experience during the pandemic about transplant?
Sorry for missing this talk. So COVID obviously has impacted transplantation significantly. We were doing a study for the Indian liver transplant registry, for which we're collating data. Cadaveric transplant has almost stopped in the country for the last 4-5 months. Apart from a few donations in Mumbai and in Kerala, there's been no substantial donation activity. Deceased or living donor activity also has decreased by almost 50 to 75%. So we have been trying to balance the urgency of liver transplant for our patients versus the risk that the donor and the recipient would have of developing COVID. So the LTSI had come out with guidelines on testing for donors and recipients before doing a living donor transplant, which have been followed by most centers, I think. So over the last 4 months, we have done 12 transplants. These are all patients who were either ACLF or had clinical urgency or had tumors. So these are not patients. So far, even now, the low MELD patients, by which I define as MELD less than 20, are patients who we are asking to wait until such time as our COVID ICU start to empty out and the pressure on our critical care services decreases. So we are still transplanting on the basis of clinical urgency. We are following the 2 tests 5 days apart formula that was recommended by the LTSI. So far, touch wood, none of our perioperative patients, donors or recipients have developed COVID. And we have done 11 transplants, which is probably about half of what we would normally have done.